Good day. I'm Professor Olabisi Loto of the Department of Obstetrics and Gynecology, Obafemi Awolowo University. I'll be talking about ovulation induction in this lecture. The objective of this lecture is such that the student should be able to know the physiology of ovulation, should identify causes of anovulation based on proper evaluation, be also familiar with the pharmacological agents for ovulation induction, and also be aware of the non-pharmacological measures, including surgery. The picture above shows the process in ovulation. The primary follicle develops to become a secondary follicle. Thereafter, it becomes the vesicular follicle, and then ovulation occurs, leading to the formation of corpus luteum, which regresses if there is no pregnancy, and form the corpus albicans, as shown in the diagram above. Now, I have no conflict of interest to declare concerning this lecture. The aim of ovulation induction is to improve the chance of natural conception. When ovulation induction is done for the process of IVF, it is better termed control ovarian hyperstimulation. Without ovulation, there can be no natural conception. And for ovulation to occur, there must be the presence of a functioning hypothalamic pituitary ovarian axis, known as the HPO axis. The hypothalamus produces gonadotropin-releasing hormone, which acts on the anterior pituitary and then to produce follicle-stimulating hormone FSH and luteinizing hormone LH. This follicle-stimulating hormone and luteinizing hormone act on ovarian cells. It acts on the granular cell to produce estrogen and the thecal cell to produce androgen. And also, it acts on the follicle to develop to the extent that they become mature and release the matured ova inside them. The hypothalamus is located in the brain. The arcuate nucleus within the hypothalamus is composed of a collection of neurons, and when stimulated, it releases gonadotropin-releasing hormone into the portal vessels of the pituitary stalk in a pulsatile fashion, usually about 90 minutes interval. While the pituitary gland stimulates, the gonadotropin-releasing hormone stimulates the pituitary gland to produce luteinizing hormone and follicle-stimulating hormone. The ovary are acted upon by this follicle-stimulating hormone to induce maturation of ovarian follicle and eventual production of estrogen. The luteinizing hormone also modulates the secretion of androgens from the ovarian thecal cells. Estrogen, in turn, produces negative feedback on the pituitary gland. And with follicular growth, the cohort of granular cells acquire the necessary receptor to respond to the luteinizing hormone, with increasing formation of cyclic AMP. At mid-cycle, estrogen level in the circulation reaches a concentration that causes a positive feedback on LH secretion, and this is called the LH surge. Ovulation occurs approximately 36 hours after the LH surge, and as evidenced by the extrusion of a mature oocyte from the Graafian follicle and the formation of the corpus luteum. It is a well-coordinated interplay between the hormones and the appropriate receptors, and some proteolytic enzymes and prostaglandins. Now, just to mention a few things about the hormones that act in this axis. You have the gonadotropin-releasing hormone, which is a decapeptide. It is produced in the hypothalamus. Then the follicle-stimulating hormone and the luteinizing hormone are glycoproteins. They are produced from the pituitary. Then the estrogen, progesterone, they are steroid hormones. They are produced in the ovary. Inhibin is a glycoprotein which has two subunits, alpha and beta. Then the other endocrine and paracrine, hormones are interleukin, epidermal growth factor, transforming growth factor, vascular endothelial growth factor, etc. All these are parts of the thing that acts in the hypothalamic pituitary ovarian axis to end up with the ovulation process. So what is an ovulation? An ovulation is the absence of ovulation, and this can be due to, one, immaturity. For example, in a woman that has not achieved menarche. Post-maturity, in a woman that has achieved menopause, that is, she has stopped menstruating. Pregnancy, which is physiological. When a woman is pregnant, she will not ovulate. Then contraception, that is when you artificially suppress ovulation with the aim of preventing pregnancy. And then when you have ovarian dysfunction, like in polycystic ovary syndrome, you can also have an ovulation in that. And what is an anovulatory cycle? An anovulatory cycle is a menstrual cycle during which the ovaries do not release an oocyte. Chronic anovulation is a common cause of infertility. The other common causes are the male factor and the uterotubal diseases. Causes of anovulation can be divided based on the organ that is affected. You have the hypothalamic pituitary causes, like in Kalman syndrome and pituitary tumor. You have the ovarian causes, like in polycystic ovary syndrome, the resistant ovary syndrome, premature menopause, idiopathic, surgical or radiotherapy or cytotoxic chemotherapy can lead to premature menopause. Then you have other endocrine disorders that can lead to anovulation. How do you diagnose anovulation or ovulation? You have to start with a proper history. Menstrual history is very important in the sense that a woman that is not menstruating is not likely to be ovulating. So you have to take a proper menstrual history. Usually take the preceding 6 months. Then you can know that somebody is menstruating by also taking the basal body temperature doing the charting. Usually you have a biphasic rise in the basal body temperature, which will tell you that this cycle is ovulatory. Then day 21 serum progesterone assay is a way you can confirm whether this person has ovulated in this cycle. Then ultrasound folliculometry, the use of ultrasound to monitor the development of the follicle is also important, because that will tell you how the follicle is developing until it becomes dominant, which is when you have a size of 80 millimeter and above. Then you can also use urinary LH kit, luteinizing hormone kit. The aim of the LH kit is to detect the luteinizing hormone surge. So luteinizing hormone becomes so high that it's space in the urine, and you can test it and know that this person is about to ovulate. The beauty of the LH kit is that it gives you a time of about 36 hours so that the woman can have time to travel to meet the husband if they are living apart before the proper ovulation takes place. The mid-liter phase endometrial biopsy, that is now no longer recommended. It's obsolete because you can do LH kit, you can do ultrasound, and you can do serum progesterone. It is rather too invasive to go and be taking a biopsy just for the purpose of confirming ovulation. Other causes of infertility should be excluded before you go ahead to induce ovulation. You have to be sure that the sperm count is okay. You have to be sure that the tips are patent before you induce ovulation. Now, WHO has a classification of anovulation or amenorrhea. You have group 1, 2, and 3. Group 1 is when you have hypothalamic pituitary failure, which occur in 10% of the cases. And those are the people that have hypogonadotropic hypogonadism. The gonadotropins are low, LH is low, FSH is low, and estrogen is low. So, but the prolactin is normal. And so when all these are low, if you do a progesterone challenge, it will be negative because there's no estrogen priming of the endometrium, because the estrogen is low, of course. For example, when somebody that has Kalman syndrome, anorexia nervosa, or stress-related, amenorrhea, they belong to that group 1. Group 2 is hypothalamic pituitary dysfunction. Those won't have normal gonadotropin level in their system and normal estrogen. But the problem is that the progesterone will be low because they are not ovulating. For example, in PCOS. Then the group 3 is ovarian failure, and they are otherwise called hypergonadotropic hypogonadism. In this group, the gonadotropins are very high because they are trying to force the ovaries to produce follicles. So they begin to go higher and higher and higher, but then the ovary is not responding. So that's why those people are called hypergonadotropic hypogonadism, and basically as a result of ovarian failure, because the ovary is not responding to the higher centers signals. So how do you treat anovulation? The treatment of anovulation is ovulation induction. Now the approach depends on the cause of anovulation and the type of infertility treatment you intend. Like I said earlier on, if you are trying to treat through IVF, you do what is called control ovarian hyperstimulation. But if you are trying to achieve natural conception, you do ovulation induction. And your aim is to provide a single oocyte which will be released for proper fertilization. So there are some drugs that can be used for ovulation induction, that's the pharmacological method now. And the drugs include clomiphene citrate, tamoxifen, bromocriptine, letrozole, and gonadotropin, etc. But there are some known pharmacological methods that can be embarked upon prior to the use of pharmacological agents. That include psychotherapy, for example, in anorexia nervosa, weight reduction for people that are overweight or obese. These are no pharmacological methods that can be taken to improve the chance of ovulation. The medications aim to stimulate ovulation and to correct biochemical abnormalities, and also to substitute for lacking hormones. For example, in hypothyroidism, those are substitution therapy. Stimulation of ovulation, like we say, we have listed, those are the drugs that are used: clomiphene, letrozole, HMG, FSH, human chorionic gonadotropin for triggering of the ovulation after a properly developing oocyte has been identified, and all the other adjunct drugs. So for somebody that is having PCOS, you can use metformin because it brings down the hyperinsulinemia such that ovulation can now resume. If you have androgen excess, dexamethasone can also be added. When you have elevated prolactin, bromocriptine or carbapenem can be used. When you have hypothyroidism, thyroxine can be used. And if somebody is diabetic, antidiabetic drugs can also be used. So for clomiphene citrate, it is the commonest drug that is used for ovulation induction. And it is useful in normogonadotropic, normoprolactinemic anovulation. It is much more effective if the estradiol level is greater than 40 picogram per ml. It can also be used in hypothalamic amenorrhea and in people that develop amenorrhea following the discontinuation of oral contraceptive pills, and those due to stress. Clomiphene is an anti-estrogen drug. It acts at the pituitary by blocking estrogen receptors and prevent negative feedback, such that the pituitary will continue to produce more gonadotropin. It acts at the follicular level too, and also impair cervical mucus production. And that is why when you give clomiphene, you may achieve ovulation without achieving pregnancy because of the effect on cervical mucus. Induction of ovulation is successful in about 75 to 80% of patients, but pregnancy rate is much lower, about 50%. Multiple pregnancy is rare, and ovarian hyperstimulation syndrome is also rare. But people have been worried about the possibility of developing ovarian cancer from repeated stimulation of the ovary. There are two preparations that are available. We have the enclomiphene, which is a potent anti-estrogen, and the zuclomiphene, which is a weak anti-estrogen. So pregnancy rate, like I said before, is about 50%. And the reason for reduction in pregnancy rate is due to premature luteinization, luteal phase defect, cervical hostility, and other non-ovulatory factors. The dosing schedule has to be titrated with response of the woman for different cycles, and the multiple pregnancy rate is about 5%. Side effects of clomiphene include hot flushes, nausea, vomiting, headache, visual disturbances, and rarely ovarian hyperstimulation syndrome. Other therapy include metformin, which we have talked about, dexamethasone, thyroid hormones, growth hormone, dopamine agonists such as bromocriptine, carbapenem, quinabolide, and then estrogen too can be added to improve the chance of success. The second drug we talk about is letrozole. It's first-line therapy in clomiphene-resistant women. It's an aromatase enzyme inhibitor in the granular cell. It suppresses estrogen synthesis and increases release of gonadotropin from the pituitary. It's usually given as a dose of 2.5 milligrams from day 2 to 6 of the cycle. Advantage of letrozole is that it has no peripheral anti-estrogenic effect on the endometrium or the cervical mucus. Pregnancy rate is comparable with clomiphene. multiple pregnancy rate is very low. Tamoxifen is another drug that can be used. It's a competitive inhibitor to estrogen at the receptor site, and it decreases antitrophin 3 and increases sex hormone binding globulin level. So it has similar to clomiphene citrate and is given as a dose of 20 mg daily for 5 days in case of intolerance to clomiphene citrate. So tamoxifen can be used. Human coronary gonadotrophin, or HCG, is useful in an ovulation due to failure of LH surge. We said LH surge is the one that triggers the final maturation of the follicle. So if there's failure of LH surge, there won't be ovulation, despite the fact that there's a properly developing follicle. So it is given at a dose of 5,000 international units 7 days after the last dose of clomiphene citrate. But you must monitor the serum estradiol and follicle before you give HCG to prevent the occurrence of ovarian hyperstimulation syndrome. Now, gonadotrophin can be used, but you must satisfy some basic prerequisites before you give gonadotrophin. You must know the ovarian reserve of the patient, and age is the strongest determinant. The younger the woman, the higher the response to gonadotrophin. Follicle stimulating hormone level of greater than 10 international units per liter on day 3 is suggestive of poor ovarian reserve. So you must do all this before you start a woman on gonadotrophin. There are several tests that can be used to detect reduced ovarian reserve, and that include day 3 FSH, day 3 estradiol, clomiphene citrate challenge test, anti-malarial hormone, and low basal serum hemoglobin. Those are things that you can use to detect the ovarian response. Reduced intrafollicular count can also be used to monitor ovarian response, which is done with an ultrasound. Indication for gonadotrophin include hypogonadotropic hypogonadism, failed clomiphene treatment, clomiphene resistance, and unexplained infertility. There are various types of gonadotrophin. Human menopausal gonadotrophin, or called PEGONA initially, which consists of 75 international units of luteinizing hormone and 75 international units of follicle stimulating hormone. Purified FSH, which has 75 IU of FSH with minimal LH. Highly purified FSH, which consists of 75 international units of FSH and very little LH activity. Then recombinant FSH, which is developed through the recombinant DNA technology. These are the various types available in the market that can be used. Several protocols for ovulation induction with gonadotrophin are available, but usually people start from day 2 to day 5 and continue for 7 to 10 days. Transvaginal ultrasound is done to monitor the follicular growth until you have a diameter of 18 to 20 millimeters for the dominant follicle. That's when you can trigger with the administration of HCG, and then you can time intercourse after that or perform an IUI, 36 hours later. Contraindication to use of gonadotrophin include primary ovarian failure with raised FSH, uncontrolled thyroid or adrenal dysfunction, sex hormone dependent tumors. All these are contraindications to the use of gonadotrophins. Pregnancy rate is as high as 90% if properly used and if other conditions are satisfied, like if the tubes is patent and the sperm count is normal. Multiple pregnancy rate is about 10 to 30%, and there's a risk of miscarriage of about 20 to 25%. Gonadotrophin releasing hormone, can also be used, but you have to follow it in a pulsatile manner to try and mimic the physiological way in which it is delivered. Indication for it include hypothalamic amenorrhea, hypogonadotropic hypogonadism, and you can also use in case of hyperprolactinemia. The use is indicated in patients that are refractory to gonadotrophin, patients with elevated LH, and patients with normal gonadotrophin. Premature follicular luteinization or premature LH surge is also an indication for the use of gonadotrophin releasing hormone analog. Part of the gonadotropin-releasing hormone analogs that are in use include buserelin and naphreline, which are given intranasally or subcutaneously. Several methods of use are available, especially in the process of IVF. You have the short protocol, the long protocol, and you can use for triggering the ovulation in the antagonist protocol. Adequate suppression is when the FSH level is less than 10 internal units per liter, or estradiol level is less than 10 picogram per ml. So it blocks the gonadotropin-releasing hormone receptor without any flare effect, and it is advocated, that is the antagonist now, in the antagonist protocol, it advocated to prevent premature LH surge. It is useful in the prevention of OHSS. In fact, when you use antagonists, hardly will you get OHSS. But when you are using antagonists, you must use agonists to trigger the ovulation instead of using HCG. Cetrorelix is an example of antagonist. Surgery. Laparoscopic ovarian drilling or laser vaporization has been used successfully to induce ovulation in women with polycystic ovary disease, which are resistant to ovarian stimulation with drugs. Then, if you have a woman with pituitary prolactinoma leading to excessive prolactin in the system, you may need to go and remove it surgically, especially if you have macroadenoma in the pituitary. Macroadenoma are those ones that are big enough, causing excessive production of prolactin in the system. Surgical removal of functional ovarian or adrenal tumor is also indicated in case where this is detected as the cause of the problem in the woman. Well, a brief talk about the ovarian hyperstimulation syndrome. This is rarely encountered when you are using clomiphene citrate, but it's very common, though not too common, but it's common to see this in the context of in vitro fertilization, process. Because what we do there is to do what we call controlled ovarian hyperstimulation. And because you are aiming to develop so many follicles, there's a chance that you may end up with ovarian hyperstimulation syndrome. It is worse when the woman gets pregnant. It gets worse because it thrives on the presence of human chorionic gonadotropin. It usually occurs 3 to 6 days after administration of HCG, and it could be mild, moderate, severe, or critical. The risk factors for OHSS include the young age, less than 30 years, people that have polycystic ovary syndrome, where you have serum estradiol that is greater than 2,500 picogram per ml during stimulation cycle, or rapidly rising estradiol from the previous day. When you have ovarian necklace sign, which is when you have multiple small follicles, this is a sign of OHSS. This is a sign of PCOS, and so they may end up developing OHSS. Then, when you administer, high dose of human chorionic gonadotropin, this may also occur, and it's common in multiple pregnancy. In summary, ovulation induction aims at restoration of monofollicular development. Intense monitoring is mandatory to prevent complication. Treatment response is actually usually determined by the individual patient's characteristics. Patient-tailored treatment response may further optimize the result of ovulation induction. Thank you for listening.